Hi everybody, my name is Dr.Sharan Srinivasan. I'm a stereotactic and functional neurosurgeon and head of the Department of Neurosciences at the Bhagwan Mahavir Jain Hospital, Vasant Nagar, Bangalore. We are having a series of videos on stroke, or what we actually, a more technical word now called brain attack. We want to create awareness among the people to make sure more people are saved and more people are back on their feet. So this particular episode I'm going to talk about is the acute care management of an ischemic stroke. All right. So stroke. Most of you would have heard this word stroke. Heart attack. I'm very sure most of you and all of you have heard this. Which creates a flutter in your heart or a stress in you? The stroke or the heart attack? I'm very sure it is the heart attack. Correct? Because heart attack means you think life is at risk, I'm going to die or he's going to die and I have to get to hospital urgently. It's a life or death situation, something has to be done, and so on and so forth. But the same kind of response is not evinced when you hear the word stroke. We neurologists, neurosurgeons are very tired of this lack of response even among educated people in this world today, and this is a global phenomenon. Hi everybody, my name is Dr.Sharan Srinivasan. I'm a stereotactic and functional neurosurgeon at the Bhagwan Mahavir Jain Hospital, Bangalore. Because of this lack of response, which is similar to a heart attack in a stroke, many years ago, the global community of neurologists, neurosurgeons decided to rename stroke as brain attack, hoping that heart attack, brain attack will evince the same kind of response, same kind of urgency, same kind of panic, because only when you panic, you take action. No panic, no action. बाद में देखेंगे, नाले नोड़ना, I'm too busy, something more important is coming, so on and so forth. So once the stroke happens, which is basically the common language of stroke is lakwa, of paralysis, which is one side of the body not working, or some speech is gone. But it has so many symptoms, and you've all heard about this in our past videos. Today I'm going to talk to you about how to diagnose and manage an acute stroke. Imagine somebody known to you has a headache, sudden slurring of speech, some hand weakness, some numbness in the hand, some difficulty in walking, some giddiness. It can be a combination of these symptoms, one of these symptoms, depending which area of the brain is getting affected first, or sudden becoming unconscious, vomiting, epileptic fits or seizures, a lot of different things. Commonly, patients are brought to me saying that he fell in the bathroom. Truthfully, he didn't fall in the bathroom and become unconscious. He had the stroke, became unconscious, and then fell in the bathroom. We call it, was it an ictus and then the problem, or the problem and then the ictus? Like slipping and falling and becoming unconscious is a different story. Having the problem and becoming unconscious and falling down is a different story. The story is different, the problem is different, the treatment is different, the outcomes are different. Okay, so this is very important for us to know the story of every patient. So assuming this patient has had what we call as the commonest stroke that we know is called the ischemic stroke, and he is brought to the emergency within the so-called window period. There's a window period for acute ischemic stroke, and for the supratentorial strokes, the window period is up to 6 hours. Earlier the better. Sometimes for the vertebrobasilar strokes, the window can be up to 24 hours. So that's a different story. But patient comes in immediately. The patient needs to get an MRI done, and where MRI is not possible, at least CT scan. And in acute ischemic strokes, what's the interesting thing? In the acute phase, early phases, CT is normal and routine MRI can be normal. Only a DWI sequence, which is called a diffusion weighted imaging sequence, will pick up the stroke. So if that DWI is also normal, patient having symptom, we just wait and watch because we call it a TIA, a transient ischemic attack. If the DWI is positive and the routine MRI is normal, that is the time we do something called thrombolysis. This ischemic stroke happens because the blood vessel or the pipe that is carrying blood to the brain gets blocked because of clot inside the blood vessel. okay, a clot or a cholesterol plug or something inside blood vessel, because of which the brain beyond that obstruction or that block does not get blood supply. This is the similar thing that happens in the heart, right? In the heart and causing the stroke. Sorry, causing the heart attack. It's something similar. So the funda is the same. This happens in the heart, that happens in the brain. The risk factors are the same smoking, same cholesterol, same BP, same sugar. The risk factors are common here. So we are assuming that this is a clot which is blocked inside the blood vessel. So we give something to bust the clot or dissolve the clot. So we have clot busting drugs available, either tenecteplase or Actilase, the couple of medicines available. So that has to be given to bust this clot. Now the commonest thing that is given IV is given in an IV here, and we are hoping that that goes all the way to the brain as a part of the circulation and dissolves it. These are good when the clots are more distal, as not in the proximal blood vessels. How do you know it's proximal distal? When you do an MRI brain stroke protocol, not just routine MRI brain, it's called MRI brain stroke protocol, then the angiogram or the study of the blood vessels of the brain becomes part of this study. So that shows us whether the proximal vessel is blocked or the distal vessels are blocked by what we call as the cutoff. If the proximal vessels are blocked, then this IV does not usually help. Then we go to the next level of treatment, which is intra-arterial thrombolysis. What does that mean? That means that we can't give the same injection here. We have to take the patient, rush the patient into a cath lab. A cath lab is a special area where angiograms are done both for the heart and for the brain or any other part of the body. We rush the patient there, and an endovascular neurosurgeon will actually put a puncture in the thigh or in the hand, and put a vessel, a catheter right to the check which area of the brain is clotted, and go there and give the injection directly onto the clot, so that you are sure that 100% medicine reaches the clot and busts the clot. But sometimes when the clot is too big or stuck nicely to the blood vessel, this doesn't work. Then we do the next level of therapy at the same time, called a thrombectomy or a mechanical thrombectomy. So the same person, what he does, he puts a wire beyond the clot, puts a basket, opens it and pulls the clot back. So you can see the accompanying video showing all these things and the piece of the clot on the gauze piece. This is what all this is showing. All right. So once this is done, the blood flow is re-established. So far so good. Sounds like a great story, science fiction story, and you expect they all lived happily ever after situation. Does it happen in every patient? Not necessarily. I've had dramatic situations where the moment the blood clot is removed on the table and the blood flow is established, the patient's hand improves. Somebody who was not moving one side suddenly lifts up and starts moving both sides. So that's dramatic. Does it happen in every case? Not necessarily, because if the brain is permanently damaged, then it becomes difficult. Now, how do you know which brain is permanently damaged, which brain is not permanently damaged, or what is the chance of recovery of this weakness or this disability following the stroke? So we do, when we do the MRI, there's something called a perfusion scan or the perfusion mismatch we see in a certain sequence of the MRI, where we see something like in a lunar eclipse, you have something called the umbra and the penumbra of the shadows that is there. If you don't know about it, Google and search it. What is umbra and what is penumbra of the lunar eclipse? Similarly, we have an umbra and a penumbra in a stroke. The umbra is the core of the stroke, where there's the maximum number of damaged or dead neurons of this one. The penumbra is what is reversible. So this perfusion mismatch is how big the penumbra is with related to the umbra. The bigger the difference is, the better the outcomes are following all these procedures. If the umbra and the penumbra looks the same, the outcomes are very poor. So can you see, it's not just about doing a scan, looking at a image and doing a procedure and thinking of you're getting all the results the same. It is not a carpet bombing procedure. There are a lot of decisions that are made by different groups of people. It has to be done fast, it has to be done accurately. Based on those decisions, right actions have to be taken. And only when this entire team works in symphony, like how the song is beautiful in a symphony, it's the same way you'll get beautiful outcomes. Why am I saying all these things? Because every hospital may not have this entire team working in unison like this to produce these magical results. I am proud to say that Bhagavan Mahavir Jain Hospital is one such institution in the heart of the city, which has these facilities available round the clock, 24/7 by 365, and you can be rest assured that you can blindly bring your loved one to the emergency any time of the day or night, and we will get the best service possible, and we deliver these promises there. Eventually, whether the patient will survive or die, whether the patient will become normal is the destiny. But the right thing has to be done at the right time completely by a dedicated group of professionals for this to happen. So this is the story of what I saw in acute ischemic stroke, which starts with IV thrombolysis to intra-arterial thrombolysis to mechanical thrombectomy. Alright, now sometimes when ischemic stroke comes outside the window period, or in spite of the window period, the brain is permanently damaged, then what happens is the stroke is completed stroke. Entire brain becomes black. You see the image on the MRI scan below, or the CT scan, you will see the entire that area of the brain is damaged. Now, once that happens, it has its own journey. Next 24-48 hours, the clot the edema can become bigger, and we have to do a decompression. This is a life-saving, threatening problem to the patient. Another problem that happens even when we give IV thrombolysis and the clot disappears, or sometimes the body spontaneously dissolves the clot by itself. What happens is the moment the clot has dissolved after some time, the blood flow is established. So it must be good news for you. Yes or no? Why am I saying yes or no? Because the good news is that this circulation is re-established. The not so good news is in that period of the block and the release, that time that has happened, the brain would have got some damage happened. So all of us have a checkpost in the brain called the blood-brain barrier. Now this blood-brain barrier in that affected area can get damaged. If that happens and reperfusion happens, bleeding happens through the damaged blood-brain barrier. So you can get a hemorrhage into an ischemic brain infarct because of reperfusion. We call this reperfusion hemorrhage. This is also a risk when you give IV tenecteplase or IV actylase or any of those clot busting drugs. So this is an inherent risk that we have. So if you remember that My Way or the Highway video of mine where we gave this tenecteplase on the road, did my patient have this risk? Absolutely. Did I explain the risk to the patient? Absolutely. Did we still take the risk? Absolutely. No risk, no benefit. You have to understand that, because the risk of not giving is much higher than the risk of giving. That's where you weigh the pros and the cons and you pray to God and give the decision, and rest is destiny that's going to determine what's going to happen. Many times they all lived happily ever after, more often than not, if you do the right thing at the right time. So coming back to this story, if there's a delay with this, there's a large infarct which is causing pressure, patients can die. We may have to decompress, many weeks or months in ICU, semi-conscious, unconscious, ventilator, tracheostomy, PEG tube, bedridden, bed sore, and many of these patients never make it, or they make it just to sitting, standing with support, some half speech, no memory, partial memory, half visual field gone, too many problems. Why am I telling all these gory details? Is because to make you understand the urgency in stroke to come quickly. Time is brain. Please remember this, time is brain. Every second we lose, that many neurons, that many circuits get damaged, and that many faculties that you will lose. Okay, so all that you heard right now was how to have treatment in acute care in an ischemic stroke. There's many more nuances to this. It is just an overview. I hope you liked it. There are many more videos that you can click on links below to see. Don't forget to wait for the next of the series of videos that I promised you that we are doing on brain attack or stroke. The next video is on hemorrhagic stroke or intracerebral hematoma or ICH.